On this episode, we aim to shed light on this commonly misunderstood topic. Welcome to Focus on Health, a show on all matters health, wellness, and lifestyle. I am your host, Joy Bofenda, and joining us today is Dr. David Wairoto, a psychiatrist and member of the Kenyatta University Wellness Center, who will be taking us through these very interesting topics. But before then, take a look at the health update.
Okay, so my name's David Kagwe Wairoto. I'm the chairman, Department of Psychiatry and Mental Health, School of Health Sciences, Kenyatta University. I'm also a lecturer in the same department. I'm glad to be here. So OCD is a short form for Obsessive Compulsive Disorder. So this is a common mental disorder which is classified as a form of anxiety disorder. It's characterized by patients having recurrent intrusive thoughts or images which disturb their lives. It's also characterized by patients having compulsions. And a compulsion is a repetitive behavior which patients cannot manage, and they find themselves doing those compulsive behavior to be able to meet a certain need. OCD is a disease which actually affects certain individuals, and it may actually be quite debilitating for these individuals. Okay, so the number one cause of OCD we find for many of our patients is patients who have mental disorder. So patients who have what we call bipolar mood disorder. And bipolar mood disorder is a chronic disease which is characterized by episodes of extremely low and profound sadness, which alternates with episodes of extremely elevated mood. So those patients are at risk of having OCD. Patients who have substance use disorders, whether they are using alcohol, cannabis, these are patients who are more likely to develop OCD. Patients who have what we call somatization. These are patients who have what we call sicknesses without a known cause. So they may come with severe chest pain, severe back pain, or even patients with depression. These are patients who are extremely prone to develop OCD. So patients with pre-existing mental disorders are more at risk of developing obsessive compulsive disorder. So the most common obsessions, we can start with obsessions first. The first one is these patients will actually have thoughts of keeping themselves extremely clean. So they may keep extremely clean. They'll have obsessions of recurrently going to check on whether they are safe in their homes. So they'll keep opening and closing the door. These are patients who will also have extremely bad thoughts about taking care of themselves. Okay, they'll keep washing their bodies and doing certain obsessions. For compulsions, these patients will want to clean their house. They'll want to do recurrent things, perhaps go to the shopping mall, avoid people. So with compulsions and obsessions, they are recurrent, and most times they occur commonly together for most patients. Now, for children to develop OCD, it can happen, but it is rare. But for children now to develop OCD, these children have to have developed a mental disorder by the time at least they are 7 or 8. So for these children, I would say they need an expert assessment. And remember, for children, the assessment is not straightforward. Remember, we'll talk to the parents, we'll talk to the teachers, we'll talk to the child using someone called a play therapist before we diagnose them as having a mental disorder. Yes, they can occur, but they are rare. For some patients, they may have OCD without another mental disorder. But in many cases, in 98% of the cases, the doctor or the psychiatrist or the mental health worker, on doing a more thorough assessment, they'll actually find another existing mental disorder. So for 98% of the cases, yes, there's a mental disorder. For those cases where you may say it's not happening, it's because perhaps you've not done a thorough assessment, or the mental disorder is still silent, or you have not diagnosed it. Now, in Kenya, unfortunately, we don't have good statistics, so we capture OCD unfortunately, with other anxiety disorders, and in Kenya we say around 3%, but in 2008 Professor David Ndetei and Francisca Ongecha, who is one of our faculty here, did a study, and they found a prevalence of 12.9% of anxiety disorders. Unfortunately, they did not classify OCD, but we believe the range is around 3% there of other anxiety disorders. So OCD affects, unfortunately, females more than males, as we said earlier in anxiety disorder. So the reasons may not be clear, but we believe it's because women have more of the emotional factors. In families, they are also the cornerstone of the home. They are the homemaker. So unfortunately, they are predisposed to develop obsessive compulsive disorder more than males. So OCD can lead to panic attacks, especially if the patient's obsessions or compulsions become extremely severe. So these patients will come with saying they are out of breath, they can't breathe, they have chest pains, they are feeling their heart is beating extremely fast, they are lightheaded. Some may say they feel like they want to die. For these patients, they need a very quick assessment in accident and emergency or casualty, and the doctor there or the healthcare worker will be able to give some medicine which will act extremely fast to relieve the symptoms. What I would say to the viewers is, when anyone has recurrent obsessions or recurrent compulsions, anytime you find that your family, your friends have noticed that this behavior you are doing is out of the ordinary, this is the time to seek care. For OCD, the treatment plan is quite easy. The cornerstone is therapy, but we have a big role of some certain medications we call selective norepinephrine reuptake inhibitors. I'll repeat again, selective norepinephrine reuptake inhibitors, SNRIs, which are commonly available in the Kenyan market, and the doctor or psychiatrist will prescribe these medicines together with therapy, and you'll have a good progress and a good outcome on treatment. Now, for OCD, that's a good question. The diagnostic criteria, the first thing you need to do is have an assessment, okay? And by assessment in mental health, we mean the healthcare worker will sit down with you, your family, your guardian, your colleagues, take a thorough history. And for mental health, a thorough history may even take an hour, it may take 2 hours, because the doctor will capture the opinions of all the family, capture what the patient feels about their sickness, and then the doctor will do something called a mental status examination, what we call MSC in psychiatric jargon. Once the doctor does a mental status examination, they'll be able to come up with something we call a diagnostic formulation. Okay, a diagnostic formulation means the doctor will now come up with a diagnosis. Once they come up with a diagnosis, they are also going to confirm with something called some tools, psychometric tools. Okay, so we are going to do some questionnaires, okay, and we have a few questionnaires for OCD which are available. Once they confirm with psychometrics, they may also do some blood tests to confirm that it's not being caused by a medical disease or disorder. Some may even order some brain tests. Once they confirm, they'll be able to now start treatment. And we said the treatment is composed of medication, which we call SNRIs, selective norepinephrine reuptake inhibitors, and also therapy. Yes, as we said, with generalized with anxiety disorder, the genetic predisposition is there. Okay, the evidence is not very clear, but we believe that for all mental disorders, genetic predisposition is key in developing these diseases. So we find in families which have a form of anxiety disorder, whether generalized anxiety, whether social phobia, whether OCD, whether panic disorder, whether agoraphobia, these are patients, unfortunately, who will be predisposed to also develop OCD. So the line is, the family will notice That's why for mental health work, we really rely on family and guardians. So you find when someone is going to clean their hands 20 times a day, they touch anything, they clean their hands. During COVID, I remember one of my patients used to come with a sanitizer, a spray. So they spray where they are sitting, they spray the air, they are extremely clean. Those individuals, you'll even find their hands are red because of always using washing soap. So for those patients, the family will notice there is a problem and they'll bring them to hospital. What I'd like to tell the viewers is, if you notice one of your family members are behaving abnormally, for OCD it is abnormal. Okay, we wash our hands perhaps after visiting the washroom, perhaps before eating, but you find someone washing 20 times, that is not normal. That's an individual who will need treatment and assessment. And as I told the viewers, this is easily treated. OCD is easily treated. They respond extremely well to medicine. So it's a case-to-case basis. For some patients, they will not need medication. Now, the reason why I'm saying it depends on case to case is because, unfortunately, some patients will have poor coping mechanisms. These are individuals who will not be able to deal with stress or pressure. Some individuals are extremely good at managing pressure. These are individuals who do what we call stressful occupations. People in healthcare, people in disciplined forces, people who perhaps auditors. These are guys who have known to deal with a lot of pressure. So for this individual, psychotherapy will work. So therapy by itself, but by an OCD specialized therapist. For OCD, we need a psychotherapist who is extremely good and competent with managing OCD. If you get that individual, it will work very well. But for many patients, unfortunately, their coping mechanisms are poor, so we'll have to give dawa or medicine.
We're taking a short commercial break. Do not move a muscle. We'll be right back. But before then, take a look at the Did You Know segment. Welcome back to Focus on Health, and like we said, we are having Dr. David Wairoto, who's taking us through obsessive compulsive disorders.
So that's a good question. OCD can actually make some patients to develop substance use disorder because they will actually use the substances to manage the obsessions and compulsions. Some patients may actually develop what we call psychosis, and psychosis means that patients have bizarre behavior. They may start walking around naked. They may start shouting. These patients, you'll actually find that they need urgent intervention. Yes, so OCD can actually predispose you to develop another mental disorder. But as we said earlier, in 98% of the cases with OCD, there's a pre-existing mental disorder already. So the role of therapy is important. The psychotherapist is meant to address either the obsessions or compulsions. So we do something called cognitive behavior therapy. And in CBT, the therapist is supposed to change the way patients process information and how they deal with stress. So we are actually meant to train the patients on better ways of stress management, better ways of dealing with normal life stresses, and also help them deal with future stresses or pressures in life. CBT is a very intensive therapy. For many patients, it's extremely draining initially, but once they do 2 and 3 sessions, they improve dramatically. So they encourage patients to know that there is a hope with CBT, and it really works. Now, the medicine which I believe viewers are talking about from your question, we have medicine which we give to manage what we call psychosis. And I said earlier, psychosis is someone having bizarre behavior. People talking too much, perhaps being extremely aggressive. Individuals who we feel may at risk of injuring other people or injuring themselves. Now, those medications we give are what we call antipsychotics, and antipsychotics may actually have many side effects. But what we tell our viewers is the other medicines which we give for OCD, which are called selective norepinephrine reuptake inhibitors. These are extremely safe medications. They don't have many side effects. The major side effects we have with them is the normal side effects with all medication: diarrhea, nausea, vomiting, a bit of headache. And remember, viewers, all medicines have side effects. Even your good old paracetamol, which you take for a headache, even your good brufen you take after doing a jog and you feel your muscles are tense, all of them have side effects. But a trained doctor or healthcare worker will be able to give you a correct dose of medicine without encountering side effects. And unfortunately, if you develop a side effect, talk to your doctor. They'll be able to reduce the dosage or even switch you to a better molecule. So please, viewers, if you feel that some of the medicine you are taking are making you feel unhappy or sad or making you feel more sick, please go see your doctor. And if you feel your doctor is not answering your question, in healthcare we say always seek a second opinion and even a third opinion, and you'll get the help you deserve. We sometimes admit these patients, but unfortunately studies have shown that OCD is best managed in an outpatient setting. So for OCD or obsessive compulsive disorder, the gold standard is we manage them in an outpatient. Once you start admitting these patients with OCD, unfortunately, it's as if you're actually making them this behavior, you're giving it even more weight. Okay, and remember, if you have a good psychotherapist, you'll be able to manage the OCD. So yes, the only patients we may admit for OCD are perhaps patients who are at risk of committing violence. Okay, so patients who are at risk of committing violence, one, those ones we'll admit either to themselves or others. Or number two, very important, patients who are at risk of actually committing suicide. So for violent patients and patients at risk of suicide, these patients will admit them for support and for treatment. But the admission also will be extremely short as well. So some researchers have actually said autistic children may have some obsessions. But remember, with autistic disorder, we call it a neurodevelopmental disorder. This is a disorder whereby part of the brain actually has some problems during normal development. So children with autism will unfortunately not be able to socialize with other children. They may struggle with normal academic performance. Some of them may develop some recurrent obsessions or compulsions, unfortunately because of the disorder. But remember, with autism is a disease which needs what we call a team approach. So apart from the psychiatrist who will only come in to manage autism when these children are perhaps at risk of harming themselves or harming others, the main person to manage an autistic child will be your pediatrician, who has a specialty with neurodevelopmental disorders and what we call occupational therapists. So yes, there is a role of OCD and autism, but autism is a different subject altogether, and it's a disease which is best managed as a team approach. So what I'll tell viewers is, if you suspect your child perhaps is lagging behind or is not at the same level with the other children, go see your pediatrician. All pediatricians actually have competence in identifying children who have developmental problems, and they can be able to do a good assessment and screen for them. Okay, so for patients with OCD, I would tell them that for their disease, they have to come see a healthcare worker. They cannot treat themselves. For OCD, it's a specific hospital. You have to go see the doctor or the psychiatrist or the psychotherapist. There is no, you can't be able to manage OCD by yourself, unfortunately. Okay, so yes, some patients may develop what we call shear. Okay, so what maybe you are talking about is perhaps coping mechanisms or strategies. So yes, with OCD, with the help of a psychotherapist, you'll be able to develop these ways of helping to avoid the OCD. But for OCD viewers, remember, you have to seek care of a health worker. You can't manage it by yourself. Good. So like for all anxiety disorders, as you mentioned earlier, is the first thing is support these individuals. Please let us not stigmatize them. Please let us not stigmatize them. Remember, viewers, that all of us at one time will develop a mental disorder, or you'll know someone who will develop a mental disorder. No one chooses when they fall sick. No one chooses when they have malaria. No one chooses when they have tonsillitis or pneumonia. No one chooses when they get OCD. So the first thing is support them. And by supporting them, take them to hospital, enter the room with them with the doctor, listen to the doctor with them. If the doctor orders any tests, take them for tests. If they are going for psychotherapy, join them in therapy. The psychotherapist and the doctor will give you individual ways of helping that patient. Remember, for each patient, every patient has their own specific way of us talking to them, and we'll be able to tell the parent, the sibling, or the family member the individual ways to help that individual deal with the OCD or the anxiety disorder. And then very important for families, when you go there, give the accurate history. In your family, someone else may have had anxiety, someone else might have had OCD. So let's not stigmatize. Let's give the healthcare workers complete information to help them. And remember, support, support, support. If you know the actual triggers as a family, try and work on those triggers. Perhaps this is someone who's gone through a divorce or separation. Offer them support, and by doing that, you'll be able to help, treat, and manage the mental disorder. For all anxiety disorders, the gold standard is we treat you for 3 months. After 3 months, you will have started good psychotherapy with a psychotherapist, and the doctor will wean off the medication, and you'll continue with therapy for an additional 3 months. After 6 months, you'll be cured. So for OCD and anxiety, 3 to 6 months is a gold standard of curing. For us psychiatrists, it's 3 months of medicine we wean off, and then you continue with psychotherapy. So the medicine, viewers, is not lifelong. We only give it for a short time. Once you get better, we stop the medication and you get better. Unfortunately, OCD cannot be prevented. Some patients are predisposed to develop it, and all we do as healthcare workers is intervene when they get overwhelmed. But what I would say is, if someone has a mental disorder, like I mentioned earlier, bipolar mood disorder, substance use disorder, major depression, if you treat these mental disorders well, you'll prevent these patients from actually developing OCD. Okay, so the myth I've heard about OCD, some people believe it's caused by bewitching, and in certain communities in Kenya, people have a big belief on people being bewitched. Someone threw some funny water or something in your house, your parents' house, and you developed OCD. What I want to tell the viewers is it's not being bewitched, please. It is a mental disease. And remember, viewers, it's also not caused by any superstitious thing. These are things which are mental disorders. They are well known. Experts have been able to review the literature and come up with expert ways of treating them. And all these expert ways are available in Kenya and locally. Also here at Kenyatta University, we are able to treat them. Okay, so my parting shot with OCD is that OCD, or obsessive compulsive disorder, is a form of anxiety disorder. It is not as common as many people think. The most common anxiety disorder is generalized anxiety, social phobia, and panic disorder. And OCD is usually caused by a pre-existing mental disorder, and once you find someone having OCD, a healthcare worker has to intervene with 1, medication, and number 2, therapy. The prognosis is good when treatment is instituted early. And for some few individuals who have extremely good coping mechanisms, psychotherapy, or what we call individual therapy, is adequate to treat OCD.
There you have it, and just as Dr. David Wairoto has said, OCD is a form of anxiety. I have been your host, Joy Bofenda, and until next time, stay safe, stay healthy, and live with the Healthy You segment.